Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hardworking Americans and their families? You will. This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefit in benefit plan. Now prepare to learn, plan, save, and protect with the Phia Group.
Well, hello there. Welcome to another Phia Group Empowering Plans podcast. This is a doozy, folks. If you've never tuned in to an Empowering Plans podcast, this is the one to start with. And if you are a regular listener, get your popcorn, sit down, prepare to be entertained. It's Ron Peck. That's me, Chief Legal Officer of the Phia Group. And with me today, none other than Brady Bizarro. Brady, I like to say you're an attorney with the consulting team. You're a director level leadership with and Adam always makes fun of the acronym LACARA. Is that right? Senior director with LACARA. What is it?
That's right.
And what is it? Legal Compliance and Regulatory Affairs. Brady, we got to do something about it. It's just, I used to think it was great as an acronym and as a team name. It's very relevant, specifically given the topic we're going to talk about today. But it's just, it keeps being made fun of. I thought it rolled off the tongue. Maybe it rolls off the tongue a little too well. Let's come up with some new acronyms once we're done with this podcast, okay? Speaking of acronyms, we had the State of the Union address, or was it the SODU? And Brady and I are just brimming over the edge, so excited to talk about what we heard, and in particular, how it relates to healthcare, health benefits, and the industry that we serve. Brady, before I turn it over to you to really dig into some of the specific health-related issues President Biden mentioned during his State of the Union address last night, a lot of time, especially up front, a lot of real estate was devoted to talk about jobs and unemployment and building new jobs. He was talking a lot about how new technology centers in the Midwest, these fields of dreams he talked about, how we're going to be building, factories to create semiconductors and chips and the future of energy, and how under his administration, unemployment is an all-time low, and that not only do people have jobs, but more jobs are on the way. And Brady, it's interesting to me because in the past, a lot of leaders and politicians and people in general that are opposed to employment-based benefits, they use unemployment and the specter of unemployment as a major knock against employment-based health benefits. Basically, they argue if you lose your job, if you're unemployed, who's going to pay for your health care? That's a risk of tying health benefits to employment. And so anytime someone talks about how everybody's employed, everybody's got a job, how wonderful, it's sort of counterintuitive or contrary or contradicts the argument that by tying health benefits to employment, it's a major risk, because here we are saying if anybody wants a job, they can have a job, which is another way of saying if anyone wants employment-based health benefits, they can have them. So I thought that was just very interesting that when you're talking about how unemployment is at an all-time low, that also means that employment-based health benefits are at an all-time high. Interesting, right? Interesting way to think about it. Another thing that was mentioned sort of along the same line is that, yes, at a time, 40% of microchips were produced in the United States, and now it's only 10%. And how we need to bring these jobs back to America, that we can't depend on other countries to provide the supply chain we need to create products, consumer goods, cars, refrigerators, appliances, he mentioned. And that, like I said, they're building these factories that are going to create 3,000 jobs there, 10,000 jobs here, and all these jobs. Brady, I think what we're missing when we talk about how we depend on overseas sources for these supplies, why do we depend on these overseas sources? It's because we depend on their cheap labor. And nobody wants to say it, but Americans will not work for the pennies that the labor force works for overseas. And so you create these jobs in the United States, but because of, and thank goodness for it, all of the protections, rights, minimums, thresholds that are in place in the United States, you can't get the kind of cheap labor here that you can get there, because we have standards for our employees. And I think he even mentioned about the right to unionize and things like that. So Brady, yes, it's wonderful to say that we're going to bring these jobs, bring this production back to the United States, but only if people are willing to work for a wage that we can afford, enough so that it's competitive with that cheap overseas labor. And Brady, one way to make a dollar go further, to provide more benefit, more bang for your buck to an American employee, is through benefits. You could add another dollar to somebody's salary in the United States, or you can provide for them $10 worth of health benefits for that same dollar of cost. If you know how to leverage buying power, negotiation power, maximize the value of your health benefits, many people would rather have our health plan, Brady, the Phia Group's health plan, than a 10% pay raise, because it is so robust and so valuable. And one last thing I want to say before I turn it over to you. He talked about how a lot of Americans are laying in bed, and he mentioned, I think, even his father, laying in bed, staring at the ceiling is what he said, thinking, what happens if my spouse is diagnosed with cancer? It's going to bankrupt me. I'll have to sell the house. I'll have to take on 2 jobs. Brady, you and many of our listeners know that not too long ago, it's only been about 4 years at this point, but it feels like yesterday, my wife was diagnosed with cancer, and she fought non-Hodgkin's lymphoma, a rare form of it. Scary prognosis. She treated with some of the best providers, not only in the state, but in the country and the world. Our out-of-pocket expense to fight, treat, and cure her cancer was negligible. I think we ended up paying only a few $100s out of pocket when all was said and done. Copays, minimal. Deductibles, non-existent. Surprise bills, what bills? How? How is that possible? It's because of how our health benefit plan is structured, the cost containment measures that are in place, and the things we've done in the past to ensure the money would be there when we needed it. That is valuable. That's more valuable to many than an increase in your wage. And if we can do that, employers will be able to provide these jobs, these manufacturing jobs that the president was talking about, without having to pay an arm and a leg in salaries, by making that dollar go further with a quality health benefit plan. So, Brady, curious about what you think about what you heard, curious about some of the other issues he brought up and specific to healthcare. I know there are many items you want to talk about.
Yeah, thanks, Ron. And absolutely, the value of having quality insurance when you need it, and the case you described as well, is really unrivaled. And most people, unfortunately, in this country don't have that kind of quality access. But what you described, Ron, in your intro here is, I think, noticing the connection between economic policies, economic realities, right, in the country, and healthcare policy generally. As you mentioned, the unemployment numbers, right? You mentioned the fact that there's always talk about how losing your job might result in you losing your health coverage. Well, the president also mentioned that a record 10 million people apply to start new businesses this year. That's a huge deal. That means more jobs. That means more people on health insurance, probably on employer-sponsored insurance in certain cases where you have large employers established. So that's a good thing for our industry and for the country. And I think that's the theme of the message I heard from the president last night was, let's finish the job. He said that in various contexts related to healthcare provisions, to economic provisions, crime, opioid crisis, on and on and on. But really surprisingly to me, there was a lot more in this speech compared to years past about healthcare. A ton of things were discussed, directly, indirectly, different laws, regulations, proposals. So which ones are most important, right? I could talk for an hour, but we don't have an hour. So I'll go over some of the highlights and get your thoughts, Ron, on some of the big ones as well. But, the president started out pretty much at the top, talking about medical debt and medical bills generally, how it is the number one cause of bankruptcy in the US. And I know I've heard and read in sources that he's working on a proposal to try and curtail the amount of medical debt people have in this country. So look for that and how it might interplay with, for example, the No Surprises Act, which he also mentioned. He talked about stopping $1 million in surprise bills per month so far, right? That's great news for consumers, right? And I think those things are obviously related. If you get a very large surprise bill, it could bankrupt you. So I would expect to see further, and we are going to see more regulations on the NSA itself, but perhaps even additional action taken, right? We have this report that was just sent to Congress on ground ambulances. So that'll be coming out later this year. So that piece of legislation is really huge. Everyone in the industry knows it, and the president mentioned it there. He also talked about a couple of bipartisan laws that passed last year that we've covered as well. But again, worth mentioning, the Peck Act is a very important bill that provided expanded coverage for veterans who were exposed to toxic burn pits. We talked about the subrogation potential and the COB issues regarding that bill in the past. He talked about the FDA rule expanding coverage for over-the-counter hearing aids. That was a big deal and required, in some cases, a modification to your plan language. There certainly would be a way for people on your health plan to get lower cost access to hearing aids. That's a good thing. He talked about focusing on mental health parity and substance use disorder. We've talked about this ad nauseum, right? Everyone knows about or should know about the NQDL analysis to this point, but know that the administration will be working with Congress, I think, on a bipartisan basis to get more resources for mental health providers to probably strengthen existing laws on health plans that violate parity rules, right? This is something we take seriously. It relates to many other issues in the country, crime, policing, homelessness. So you can bet that the focus on mental health is definitely not going away and will be on a bipartisan basis, I think, addressed. We talked about the opioid crisis. We've covered that as well, about how there's been these huge settlements, right, and opportunity in some cases for plan sponsors to recoup some funds, depending on the structure and nature of those settlements that are reached with manufacturers, or in some cases, even PBMs, possibly this year. So we'll follow that. But the big things, Ron, that I think we were expecting that he talked about, of course, that passed last year, the Inflation Reduction Act, in the sort of slow trickle of impact that's had. And one thing in particular he mentioned, right, he talked about the effect of prescription drugs, the cost for Americans, how we pay the highest price for drugs in the world, how 1 in 10 Americans has diabetes. He mentioned insulin being around for over 100 years and how the inventor of insulin intended to make it free for everyone, and that how it really only costs manufacturers about $10 to $13 per vial, but yet they're charging up to $500 a month in some cases, making record profits. And so he referenced in this provision in the Inflation Reduction Act that applies to those on Medicare, which caps their cost for insulin, right, monthly at $35 per month, which of course we know does not apply yet more broadly to self-funded plans or to private insurance, but he wants to expand it. But as we know, Ron, right, there's a couple of red flags there. And unfortunately, still this almost misinformation, frankly, to the American public about what it means to cap the cost. So I was hoping you'd be eager to talk about some of the real behind the scenes data and what we're talking about when we say capping the cost and who actually pays the rest of it.
Well, Brady, I'm sure every person who watched the address is now listening to this podcast. So our sort of filling in the blanks and helping people sort of really digest and understand what it means. Hopefully we should have a universal impact on the entire population, right? No, but I do hope, it's funny, I think about this before I get started, Brady, if every person who's listening explains what we're about to talk about to two people and instructs them to then explain it to two people, so on and so forth, pretty soon we may actually make a dent. Wouldn't that be special, Brady? I guess I could dream. But, you're right. The president mentioned that the pharmaceutical companies, he said, Big Pharma has been charging, I wrote this down, Big Pharma has been charging diabetics $400 to $500 a month. You mentioned this for insulin. And he said, not anymore. And I was very excited. He said, not anymore. And everyone got up and yay! Pharma has been charging people, $400 to $500 a month. Who are people? If you're uninsured, they're charging you, the patient. If you're on Medicare, they're charging the government, right? They're charging Medicare or Medicaid. If you're on private insurance, they're charging private insurance. $400 to $500 is the sticker price for the insulin in totality. I know this because I'm a type 1 diabetic. I'm freely sharing my PHI here, Brady, so don't call the HIPAA police on me.
Got it.
I'm a type 1 diabetic. I take insulin. I have been for over 30 years. And I look at the EOBs. I know what the insulin costs in total price. And as someone who's in the industry, I recognize that when I pay a copay, if I pay a copay, but when I pay a copay, it's a portion of the total price. So if the total price is $500 and I'm paying, I don't know, $50 copay, the other $450 is being paid by somebody, and that somebody is my health plan, my health insurance. When he then says that, we're capping what people are paying, and he's talking about, for instance, he had wanted to implement a $30 max on the price, that's the out of pocket for the patient. That doesn't mean that the price of insulin is dropping from $500 to $30. It just means in my example where I paid $50 and the plan paid $450, now I'm paying $30 and the plan is paying $470. But the total price of $500 is still $500. So where he's complaining and saying, I think he said that we pay more for prescription drugs than any other nation on earth. He said that. Are you talking about the out of pocket for the patient, meaning the patient's share? Or are you talking about the total cost of the drug? Because by putting a cap of $30 on what the patient pays out of pocket, you're not doing anything about the cost of the drug. You're just moving the shelves around, right? You're just, what do they say? Moving the chairs around on the deck of the Titanic, right? You're just moving around who pays what portion. But the total cost is still the same. The cost hasn't come down. And Brady, I actually have concerns. And I know you know I have concerns. And I've shared these concerns with you. And I'm going to share it with everybody else. And here's my concern. Many health plans, not ours, but many health plans not only have a flat copay, but they have a coinsurance where the patient pays a percent of the cost. As the cost of the drug goes up or the cost of the treatment goes up, so does the share paid by the patient. The percent stays the same, but the dollar amount increases. If you put a $30 cap on what the patient pays, that actually incentivizes the drug manufacturer to increase the total cost of the drug. Here's why. If I have a plan that has me pay 10% of the total cost, if the drug manufacturer increases the cost of the drug, my 10% share is eventually going to get so high, so big that I can't afford it. I make a fuss, lawmakers come out, shake their staffs and say, this can't be, poor Ron, he can't afford his drug. So they need to set the price at an amount where the patient share is affordable by you, me, and the other patients out there. But once you put a cap on that patient share, every dollar they add to the cost of the drug now comes 100% out of the deep pockets of the benefit plan. And if we're talking about the big greedy insurance companies, fine, I get it. They'll probably increase premiums as a result. If they have to pay more, they need to get the money from somewhere. But people can point fingers and say, let them take it out of the profits. Let them take it out of the shareholders. Let it take out of the waste. Stop going on golf trips, whatever. But when we're talking about a self-funded health benefit plan like our plan, every extra dollar the plan has to pay is coming out of your pocket and my pocket. So even if my copay is capped at $30, I'm still paying for the total cost of the drug through my plan, through my contributions, or if I have insurance through my premiums. The only way to stop squeezing the American patient, the hard-working American you're so worried about, is by reducing the cost of the drug in totality, not just the upfront patient share. Because one way or the other, Brady, you and I pay the cost, whether it's upfront when we buy the drug or later when we pay our premium. If the cost of the drug doesn't come down, we're the ones who are paying for it one way or the other.
Absolutely. And Ron, that kind of in-depth analysis is something you won't get in the State of the Union address itself. The president would never think to go into that level of detail because, as we know, the political spin, right, is to just claim that you've reduced prices, right? The same thing with allowing Medicare to negotiate drug prices. That's presented as a huge win, as historic. It's going to tremendously transform healthcare. But we know in reality, it's just the top 10 most expensive drugs. Even then, only starts in 2026. And there's all these other caveats that apply. And to Ron's original point there, it does not mean that the overall price that we pay in the private sector will come down. So, again, there's so many asterisks to keep track of with certain of these policies that it's kind of mind-blowing. But in the few minutes we have left, I just want to give a quick rundown. What was discussed primarily that you should be watching? Because ultimately this speech has always and still does serve as a bellwether for the nation, right? Not just on all issues, but certainly on healthcare issues in particular for our purposes. And so keep your eye on these issues going forward. Abortion laws and the administration's response. What will happen as states continue to pass laws curtailing access? How will the administration react? And what should you know as plan sponsors? Keep an eye on the end of the COVID-19 emergencies. The president reiterated that he does intend to follow through with that happening in a couple months from now. He mentioned a couple of veto threats against Republicans who want to repeal the Inflation Reduction Act, which I think is a safe bet to say that will not be repealed this year while he still is in office. He mentioned the non-compete ban, right? Very, very important for our industry and other contexts. You talked about that in previous webinars. And finally, he also mentioned the National Paid Family and Medical Leave Act that he wants to get passed, that President Trump wanted to get passed. A lot of our clients and frankly, employees want to see passed. So let's see if there's any movement on that this year. It could be something. And one final thing I want to mention is what's not talked about was drug importation. One thing that probably really could lower drug prices, as our clients know. So not really good news for that policy since it wasn't brought up in the State of the Union speech. But of all the things that we've covered, that were talked about, there's a lot to chew on and unpack. We'll be watching as we go forward. Any last thoughts on this, Ron, before we close out?
Wow, huh? Last thoughts. It's just, Brady, I feel like we're fighting an uphill battle sometimes. You mentioned the spin and political rhetoric, and I really do feel that as people who work with employers, work with employees, it really behooves us to be as candid and generous with information as possible. We expect employees to understand how health benefits work. And when we say, hey, here's an incentive to go to a center of excellence, and we don't explain what is a center of excellence, right? Of course, their knee-jerk reaction is going to be, well, you're just trying to save money. You're sending me to a worse hospital. They charge less, so it must be worse, so that you could save money. And until people truly understand the things we're talking about today and in general, the fact that cost has no relationship with quality in healthcare, that generic drugs are no different than the brand version. If people don't understand these things, why should they trust us? When the president says insulin, $500, now it's $30, 500 is the total cost, 30 is the out of pocket. Apples to apples would have been, hey, most people pay a $50 copay. Now it's reduced to 30. It's suddenly a lot less drastic. If people don't hear that from us, they're not going to hear it anywhere. And the value of generous health benefits and the fact that we really are doing this to help, not to hurt. It's not meant to be a profit creation mechanism, especially in the self-funded market. There is no profit. It's just, if people don't understand that, we won't get this kind of grassroots support that we need in order to grow and do good for the American working public. And I just hope that our conversation today and the issues that we're talking about and just what health benefits are, how it works, and our efforts to make people just conscious, literate consumers of healthcare so that they could be savvy purchasers and advocates for themselves, that message is out there. And let's all make a commitment to explain to our families, our friends, our colleagues, and the employers and employees we service, explain how healthcare works, explain what health insurance is, explain what self-funding is, and expose the truth and show them how what we're doing really is for the greater good. That would be my message going into this. And I'm inspired. I'm inspired, Brady, by you, by your work, by what we saw today, by the discussion today, to do more of that.
Awesome.
Well, folks, that's it for today. Hopefully you got as much out of this podcast as we did. Let's keep the dialogue going. Reach out. Let us know what you think. If you have a topic or an issue that you'd like us to discuss in the future podcast, you can reach out to me directly, Peck, RPECK, at phiagroup.com, and we'll definitely attempt to cover it. Otherwise, I hope you're all well. Take care of each other and stay well. Thanks so much for empowering your plans with the Phia Group. Be well.